As we know, almost the last 20 years, multi-genetic have been involved in our clinical practices, helping in our treatment decisions. And in this, we have a lot of experience, 15 years now experience with Oncology, as we analyzed the first patient in 2008. So we have a quite rich database, and one of my slides, I'll show you some data from us. Here is the declaration of interest. So practically, each time we have to deal with a breast cancer patient with early hormone receptor positive HER2 negative breast cancer, we have to answer two questions. What is the risk that this individual patient will recur? And the second is, does he need chemotherapy? For this reason, in order to assess the recurrence risk and predict the treatment benefit, we use both prognostic factors and predictive factors. We can use risk prediction tools, even algorithms found in the internet, and the multi-gene assays. Through the years, I remind you that a few decades ago, we started prognosis with basically with PNM system. We added parameters, and we now have a long list of prognostic factors. But importantly, there are only two of them which are also predictive of treatment benefit, namely the estrogen receptor, predicting response to hormonal therapy, and HER2 status, predicting response to anti-HER2 therapy. Multi-gene assays can add to this prognostic information, and some of them, not all of them, are also predictive of chemotherapy response. This is very important to know, because in order to accept that the biomarker is predictive of treatment benefit, we should have a formal test for an interaction between the biomarker and the treatment group, and the outcome must be statistically significant. And of course, in the context of a randomized trial, mainly having two arms comparing the two treatments. And this is very important because not all of multi-gene assays have this important factor. So, does this mean
it does describe the other
okay.
Sorry.
We ignore it. So we do have a long list, and there are many more under evaluation. You can come up every day. We see new assays coming for evaluation and validation. So we have to decide, because multi-gene assays are not the same. And most importantly, they do not provide the same information. So how do we decide? The answer is we follow the evidence. We have to answer those questions. Is it prognostic? Is it predictive of chemotherapy benefit? Do we have prospective outcome evidence to support that? What is the level of evidence? Is it strong? Do we have clinical benefit? Is it clinically easy to use it? And what is the outcome? And of course, taking into consideration all this has been incorporating in treatment guidelines, because we usually incorporate in treatment guidelines those multi-gene assays where we have all these factors. So for the purpose of this presentation, I'll focus on these four, which are most widely used. And if I'm well informed, are used also in this country. So let's start with Oncotype DX. The Oncotype DX recurrence score is a standardized and quantitative assay, involves 21 genes. Sorry, I'll open a parenthesis. I'm sure that you know a lot of the data I'm going to present. However, I'll present you only the most important ones, just to remind you what we have and where we have to base our decision which multi-gene assay to use. So going back, Oncotype DX involves 21 genes, mainly from the hormone receptor group and the proliferation group, and 5 reference genes. And it has a long history since Pi presented the first study in 2004 at San Antonio Breast Cancer Symposium. The prognostic value was retrospectively validated in data from prospective randomized trials. Then we had validation, the prediction of chemotherapy benefit from trials, again, randomized trials performed by very well-known and respectful groups from the States, the NSABP and the SWOG. But most importantly is that we have these 2 trials which confirm the chemotherapy benefit we can have by using Oncotype DX. The Taylor X, including the results of 11 years, which were presented last December, and my colleague will present you more in more details, which is very, very important, because don't forget that we are dealing with hormone receptor positive disease, which tends to recur late. We are interested in late recurrences. And also, it is important that these studies are prospective, randomized, and they include 2 arms. One with hormonal therapy alone versus chemotherapy plus hormonal therapy. So we have a true comparison, because we can see that in other assays we have one single arm, and the prediction of benefit of chemotherapy benefit or not, it is based to the results of one arm in which patients receive only hormonal therapy. In the Taylor X trial, patients with a recurrence score between 11 and 25 were randomized to receive endocrine therapy alone or chemoendocrine therapy. And in the RxPonder trial, lymph node positive patients with a recurrence score 0 to 25 were also randomized to receive endocrine therapy alone or chemoendocrine therapy. In both trials, all patients with recurrence score over 20, 60, 26, based in previous results, received chemotherapy because it was proven that they will have a chemotherapy benefit. So here is a summary of all the results we have from these trials, which also shows that we can use Oncotype DX for both postmenopausal, premenopausal, lymph node positive, lymph node negative patients. So what do we have? For postmenopausal patients, irrespectively of the lymph node status, lymph node negative or positive, if they have a recurrence score result up to 25, there is no chemotherapy benefit. For premenopausal patients or patients younger than the age of 50, or node negative, up to 15 recurrence score, we have no benefit, and we start to see some benefit for patients having a recurrence score 16 up to 25, with the exception that in this group, 16 to 20 patients who are of low clinical risk, they still have no benefit of chemotherapy. As for the node positive patients, we do have in both groups from 0 to 25 an indication for chemotherapy benefit, even if it is low at the area of 2.8. And later on, if you want, we can discuss it when we can use Oncotype DX in lymph node positive patients younger than the age of 50. So if we use in the clinical practice the Oncotype DX, we can see here analysis in the Taylor X data. For high clinical risk patients, we can see that there is quite a number having high clinical risk and low recurrence score, meaning that these patients, 73%, which is quite a high percentage, if the decision to give the chemotherapy was based only on clinical status, being high clinical risk, they should have received chemotherapy. But with Oncotype DX, it is proven that 73% could have been overtreated. And in my mind, most importantly, is the low clinical risk patients, because we can see that in low clinical risk patients, 43% of them, they had a recurrence score over 26, meaning that they do have a clear chemotherapy benefit. And these patients could have been undertreated if the clinical decision was based only in the clinical situation of the patient. And I said that this is more important because here the outcome of these patients would be worse without chemotherapy. A similar analysis we are currently doing in the Greek database. We have over 8,000 patients analyzed with Oncotype DX, and currently we are analyzing patients having more than 5 years follow-up, treated between 2008 and 2019. In this group of patients, who all are lymph node negative, we collected recently the high clinical risk patients, 840 patients, and we divided the groups according to the age. And we can see here that 76% of patients could have received only hormone therapy, and for the patients younger than the age of 50, 42% of patients could also skip chemotherapy. The overall omission of chemotherapy in high clinical risk patients of in all ages is 63%. It's something parallel to the 73% I showed you in Taylor X data. So this is another proof that in Greece, and mind you, in Greece we have the unique population. There's no mixed population. We don't have colored people, so it's a pure population. And in my mind, it's of the same value as the Clarence trial in Israel, where they also had the same kind of population, compared to the States, where they have mixed population with Spaniards, Latinos, and everything. So this is very, very important, and we're working for more data from our database. So there is a lot of evidence, real-world evidence in favor of Oncotype. Overall, we can safely avoid chemotherapy in about 80% of patients. The breast cancer specific survival 9 years is over 97% in all patients having a recurrence score less than 18. We also have now strong data for node positive patients with a low recurrence score less than 18, which can help reducing by 60% chemotherapy. And something which is also very important is that the recurrence score result do not correlate with clinical pathologic features. And why I'm emphasizing that? Because a lot of people, for example, the last few years, there was a trend in, especially in the UK, to be based on the Ki-67 expression when decide about chemotherapy. But it was proven for Oncotype data that there is a wide distribution of recurrence score results by grade, Ki-67, nodal status, and tumor subtype. You can see it here, all the combinations of grade and lymph node status. You can see high recurrence, low recurrence, or for Ki-67 in the Plan B, which was also a prospective trial, a German prospective trial, for patients with less than 14. That time we considered the 14 as a cutoff point we can see for low Ki-67 high recurrence score, and most importantly for high Ki-67 low recurrence. So you can't really presume what the recurrence score would be based on the Ki-67 or the grade or the tumor site. But actually, this is why it helps in clinical decision, because a lot of times we have mixed parameters. We have large human. I still remember just cases with 6 centimeter tumor, grade 1, and recurrence score 3. So you don't give chemotherapy because the tumor was 6 centimeters. Sorry. And also with the tumor subtype. Recently, we presented at San Antonio our 500 cases with lobular carcinoma because in clinical practice, we consider the classic lobular carcinoma that has a very good outcome. And we can see here the lobular carcinoma, almost 13%, they have a high recurrence score. So even with histology, you can't predict what the recurrence score would be. And this is actually the value of the assay. And based on all this, Oncotype DX is included in all key international guidelines, which recommend the use of Oncotype DX, like ASCO, NCCN, which actually is the preferred test for prediction of chemotherapy benefit, accepted at St. Gallen, the last St. Gallen, where also the RX ponder was adopted, and also from the ESMO guidelines, which actually are not the most updated. The most updated last time it was 3-4 years, 4 years ago. ASCO was updated last year, and NCNN, well, it is updated everything. So let's move to MammaPrint. MammaPrint is a 70-gene multi-gene assay. It was validated in tumor samples of known clinical outcome from the Netherlands Cancer Institute Frozen Tissue Bank. It was a mixed population, 78 untreated cases, patients who received no treatment at all, and almost 300 partially treated cases, mixed lymph node negative, lymph node positive. It divides patients to 2 groups, those with poor signature and those with good signatures. And patients with good signature, they have a very good distant metastasis-free survival and overall survival. So the first thing we can say here that it is not an individualized prediction. With the recurrence score, for example, if you have a patient who has 5 compared to another one who has 16, we know that the 5 has a better outcome. Here, we don't have this. We have good and poor, nothing between or individualized expression. This assay was also tested prospectively in the MINDTAM trial, in which patients with lymph node positive or with negative and up to 3 lymph node positive. I don't know. That's like an alarm. Does it sound like 10 minutes or something? So I need to measure it. Right. Patients were categorized for the clinical stages using a modification of the adjuvant line, and they were analyzed with a MammaPrint assay for the genomic risk. And patients who had a discordant result, either clinically low and genomically high, or clinically high and genomically low, they were randomized to receive chemotherapy or not. The results were presented first with 5 years, and the last time they presented was in 8.7 years. So at 5 years, patients who didn't receive chemotherapy had an excellent result with no difference. You see here the distant metastasis-free survival was 95.7 compared to 94.8 without chemotherapy. and thus the prognostic value of mammaprine was proven with level 1 evidence. However, there was a change after 8 years because there was a gain of 2.6% for chemotherapy for patients who received chemotherapy, and these are outcomes for patients who were clinically high, but they have genomic low profile. And these are the results from the publication on 8.7, and I would like to make some comments to that. If we go to the group which was analyzed, high clinical risk with low mammaprine, and then we go to patients with age over 50 years, we can see that there is no difference between endocrine therapy and chemoendocrine therapy. However, as also the authors state in the publications, the numbers are very small, 450, 440, and the trial is underpowered to prove the value for prediction of chemotherapy benefit. If we go to low-risk patients, and this is also very important, despite the mammaprine result, if it is high, which simply could mean that despite the low clinical status with a high genomic status, we should receive chemotherapy. We can see here that there is no difference. So there is no clinical utility of mammaprine in low clinical risk patients. You can't get any help of that. And there is another point also for younger patients, less than 50 years of age. There is also a limited clinical utility because all of them have a chemotherapy benefit. I remind you that this trial has a mixed population, lymph node negative, lymph node positive, so we don't know the details. The numbers are very small. We have a subgroup analysis. But if we go back to the tail of X trial for lymph node negative patients, we have these two groups for the same age, less than 50 years of age. But patients with a recurrence score up to 15, they have no chemotherapy benefit. So these groups, if we analyze them with mammaprine, they would have received chemotherapy, but not with the recurrence score, the Oncotype DX recurrence score. So there are differences which are make a difference in the clinical utility of the assays. As I said before, with Oncotype DX, we have an individualized risk estimation, whilst with the mammaprine, we have two categories. Here we have mixed populations for the validation with Oncotype DX are very clear. Prognostic, both of them level 1 evidence, but for prediction, we clearly have results for Oncotype DX, but not with mammaprine, and we have 3 large prospective trials. And most importantly, there is a high discordance if you analyze the same patients with both assays. You can see that the discordance between Oncotype DX and mammaprine, the same patients, can go from 44% to 57%. This means that we can't. The results we get from each one of them is not interchangeable. They don't give you the same information, and you can see it very clearly in the Optima preliminary study, where with Oncotype DX we have 18% high-risk patients, but with the mammaprine we have twice more high-risk patients, meaning that these patients would twice more would receive chemotherapy. So if you look at those data, in this analysis with mammaprine and recurrence score, we can see that high-risk patients have low recurrence score, meaning that 28% of patients potentially would be overtreated, and low-risk patients with mammaprin in good signature have high recurrence score, and they should treat it by chemotherapy. 12% patients potentially would be undertreated if they were analyzed with mammaprin. So in summary for mammaprin, definitely it is a prognostic-only test. It has been validated in a mixed patient treatment population, the MINDAC trial, which was not powered to prove chemotherapy benefit. The algorithm was developed for the validation on a patient cohort without any treatment. I remind you that the first part of the patient, 70-something patients, received no treatment at all. And of course, the results suggest that the mammaprin clinical utility is limited only to high-risk postmenopausal patients. As a result of all this I have presented you, including the high numbers of the prospective randomized trials, 3 prospective randomized trials, 1 only in MINDAC, large population with supportive data, over 96,000 patients compared to 8,000 patients. As a result, Oncotype DX has been included in all these international treatment guidelines with a limited inclusion for mammaprin. Prosigna or PAM50 risk of relapse score includes the intrinsic subtypes of breast cancer. The PAM50 measures, there are a lot of algorithms and a lot of results. However, to the end result, to the Prosigna result. The PAM50, which is the basis measures the expression of 50 classified genes. It has been validated in ER positive, lymph node negative, and lymph node positive, but only post-menopausal women, no premenopausal women included. And the gene expression generates a risk of relapse score. And then a clinical parameter, the tumor site, is added. So the final Prosigna result we get, it is a result with mixed parameters, and also we get the result, the categorization of the intrinsic subtype of the specific tumor we analyzed. It was validated in the Austrian ABCSG-8 study. Allow me to remind you that this study included 1,500 postmenopausal only patients with early breast cancer who were treated with tamoxifen or tamoxifen followed by arimidex. But patients, there was no arm with chemotherapy. It was only a hormonal therapy trial. So it was proven to be predictive for the outcome, both for node negative and node positive patients. And the prediction was more profound in for late recurrences, as it was expected for hormone receptor positive disease over 5 years, and also for node positive patients. So there are limitations for Prosigna because the trial, the ABCSG-8 trial, addressed endocrine treatment questions in the absence of alternative therapy. There was no comparison. And of course, when we try to compare this to other assays, there is a problem because here they use a combination score of clinical pathological parameters, whilst mammaprin and Oncotype DX, they are pure genetic multi-gene assays not involving clinical parameters. Again, there is an overall discordance between Oncotype DX and Prosigna, which is something between 43 to 50%. And again, if we analyze the same patient with a recurrence score, the Prosigna risk of relapse score, we can see that if we use Prosigna, 24% of patients would be potentially overtreated, and at the same time, 50% of patients would have been potentially undertreated. So in summary for the Prosigna, this is derived from an algorithm which is based in the PAM50 gene signature, and then multiple clinical parameters are added to produce the final result. Was validated as a prognosticator, but in studies with a single arm, only hormonal therapy. And also it has been validated only in postmenopausal women. Based on that, and most importantly, that with Prosigna, we don't have any prospective data. It has been included with special indications and very limited in international guidelines. And finally, endopredict, both the EP, the endopredict, and the EP clean, the endopredict clinical score, which involves the endopredict 8 cancer-related genes, and to this score, the EP risk score, tumor size, and lymph node status is added in order to produce the endopredict clinical score. It is also not individualized, but gives us 2 categories, low and high risk category. The cutoff point here is 5 and 3.2. It was also validated in ABCSG 6 and 8 trials. Again, there is the limitation of this trial, as I said, for only hormonal therapy. And for endopredict data alone, it was predictive prognostic for both lymph node negative and lymph node positive patients. And again, both the endopredict and the endopredict involving the clinical parameters was prognostic for late recurrences over 5 years. Again, I remind you the limitations as with the PAM50, and especially in ABCSG 6, there might be a selection bias toward clinically low risk patients and only postmenopausal patients. Again, there is overall discordance from 47 to 63% for both EP and EpiClean. And also you can see here in TransAttack trial, the high number of high risk, the high percentage of high risk patients categorized by endopredict. And also when you compare it to the real world data, the SEER registry, you can see a huge difference between categories. This is the real world, and this is with the endopredict clinic, how many patients are categorized as high risk. And this is more or less for us clinicians expected, because if you involve tumor size and lymph node status, the algorithm is more likely to give you a high risk score, a high risk patient. So in summary, endopredict is not supported by data suggesting that this predictive of chemotherapy, includes nodal status in the algorithms to provide the EpiClean result with the problems where I have just shown you. The studies of the validation were only retrospective. There are no prospective data. And most importantly, it is highly, strongly influenced by the nodal status and the tumor size. Because practically, what do we want in clinical practice? We want mainly for patients intermediate and high clinical risk to find out if they need chemotherapy or not. But in this case, when you have a patient who have unfavorable clinical factors, high tumor size or lymph nodes involved, it is more or less expected that the result will be high-risk give chemotherapy. So it doesn't really help practically. And again, no prospective data, very small number of patients. And this is the reason of limited inclusion in international guidelines. So in summary, with all these 4 multi-gene assays, to the question, are they all the same? The clear answer is no, they are not. Of course, all MGAs are reflecting risk of recurrence. They do. However, they have major differences in the technological platform to measure the gene expression, the number and identity of genes assessed, patients' populations, very important, used for development and validation, prognostic and predictive information of chemotherapy benefit, the existence of prospective randomized trial results and the level of evidence of these results, the impact of non-treatment decisions. Okay, I'm finishing. 1 minute. The impact on treatment decisions and the cost effectiveness and inclusion in major international guidelines. From this table, I only put it here just to emphasize that you can't really, in clinical practice, use endoprednisone Prosigna in a premenopausal patient. So when we adopt these MGAs in our clinical practice, we have to be very careful, and because it's important to use the right test for each patient scenario we have in our practice. As I said, the information are not interchangeable. Only the Oncotype DX has been validated to estimate chemotherapy benefit and further studied in 2 large prospective trials. MGAs assess different gene panels. Information we get from another cannot be transferred to another. The Oncotype has demonstrated to estimate chemotherapy benefit using only gene expression without involving clinical parameters like the FAM50 and Prosigna. And this is why it is adopted mainly in NCCN guidelines as the advice is strongly consider Oncotype DX for your treatment decision. So my answer to why we choose Oncotype DX test for chemotherapy benefit prediction is because it is supported by the most substantial body of clinical evidence as a prognosticator, assesses the benefit from both hormonal therapy and chemotherapy with level 1 evidence, has the longest history of commercial genomic assays, now with over 1 million breast cancer patients tested worldwide, and it has incorporated no major international guidelines to help us in treatment decisions. Thank you. Thank you very much.
So good evening. I'm really glad to visit Estonia for the first time. And thank you for your time tonight to discuss about our approach concerning multi-gene testing panels in hereditary cancer, our panel that we provide hereditary test and all the results we have in the lab. We know that cancer is a genetic disease, first of all, some of the main topics we're discussing today quickly. We're going to define what multi-gene panels are concerning hereditary breast cancer genetic testing, principles of cancer risk assessment and counseling, which genes are included in such panels, who should be referred for genetic counseling for those panels concerning not only breast cancer but other cancer types, interpretation and management of results and the clinical utility of them, and finally some things about the data we share, data sharing, and our publications. So we know that cancer is a genetic disease resulting either from an inherited mutation or a somatic mutation. And although the vast majority of diagnoses are due to DNA damage and acquired DNA damage during an individual's lifetime, It is estimated today that 5 to 10% of new cancer diagnoses are due to an inherited gene mutation. So this is the value of genetic testing. On one hand, defining a person's risk of developing a disease, such as cancer in this case, and on the other hand, predicting this person's chance of passing on this genetic defect, this genetic disorder to the next generation. Now, with the completion of the Human Genome Project, the completion of the Human Genome Project has opened up the doors for significant clinical advances with a tremendous impact on cancer care, particularly in our ability to detect which genes which genetic germline gene mutations are the ones that confer increased cancer risk in an individual. So research has helped us a lot, of course, to identify mutations in many genes that we know today that can contribute to 50 different hereditary cancer syndromes. And at the same time, with the technological advantages given to us, with the high throughput application of next generation sequencing, we can define a multi-gene panel as practically the parallel sequence of multiple pre-specified genes to identify pathological DNA variation. Now, the decision to offer genetic testing involves 3 stages. First of all, the pre-test counseling before the genetic testing is ordered. The second stage is the decision of which is the appropriate genetic testing to order. And finally, the post-test counseling when the results are already disclosed. So here, of course, we need to know that we offer genetic testing to all at high-risk individual, of course, because it's likely for them to impact their medical management and the decisions, not only for them, but also for the other family members. Now, starting with the first stage, the pre-test counseling, I have picked the important notes from the NCCN guidelines. You need to start with a comprehensive, a very detailed family history, assessing information of first, second, and third degree relatives. You need to take information about the types of cancer in the family, the bilaterality, the age at diagnosis, the subtype, and the pathology of the cancers in the family. During the pre-test counseling that we offer in all of our patients, individuals being tested, they need to be informed and they need to be prepared for the 3 possible outcomes: a pathogenic variant, a negative result, or results of uncertain significance. And finally, we should advise them about possible inherited cancer risk to their relatives and how this is going to be managed. In order to decide about which is the appropriate genetic test to order, NCCN guidelines clearly state and recommend that the tailored multi-gene panel test is often the more efficient and the more cost-effective in order to detect likely pathogenic variants in the tested individuals. Usually, we start with a family member with the youngest age at diagnosis, bilateral diseases, multiple primary cancers. In case such an individual is not available, testing unaffected family members should be considered, of course, with the certain significant limitations. We avoid the genetic testing in children under 18 years old because probably the results will not affect their medical management. And this is also important when we are in front of a detected somatic pathogenic or likely pathogenic variant. It is common in some cases that such a variant might have implications with germline genes. So in these cases, in case this is the case, we should give our individuals or patients the chance of getting tested with a genetic panel like that in order to detect a germline mutation, because we need to have in mind that tumor-only sequence may fail to detect about 10% of likely pathogenic germline mutations. And finally, when the results are disclosed, the post-test counseling that we also offer to our clinicians and our patients in GeneCore includes the discussion of results and the associated medical risks, the discussion of recommended medical management options and therapeutical implications to the individuals tested, and of course, discussion of the importance of notifying the other family members and offering the resources for that they can also be tested. Here you can see the three possible outcomes, results. We're going to discuss them. Okay, I'm okay. So in case we come up with a positive result, a likely pathogenic variant, it is important to know that in patients that have already been treated for cancer, such a knowledge of pathogenic variant might affect options and recommendations for their treatment. Also, it might give them extra information that they are at increased risk for additionally primary cancers, and we can advise them about the estimated lifetime risks of them coming up with another primary cancer. Also, and finally here, with a positive result in our hands, it should be recommend for patients on reproductive age to get advised about options for prenatal diagnosis and assisted reproduction. Now, in case of negative results are generally reassuring, of course, but we need to make sure our patients understand, the individuals tested understand that a negative result might mean that we do have a pathogenic variant in genes tested, but we have limitations in the technology that would not let us detect those variants. Or there might be likely pathogenic variants that might exist in genes outside the genetic panel we've already tested. So, in case we have a negative result, but we have a strong personal or family history, we need to make sure that our patients understand they need to consider increased screening and risk reduction measures for cancer based on this family history. And finally, it's often when you add genes in your genetic panels to come across a VUS, variant of unknown significance. Just keep in mind, I'm going to come back, these results should not be used to alter medical management. What we say to our patients is like you're taking a negative result. Now, and the major question is, which genes are included in multi-gene panel testing of hereditary breast cancer? You need to offer to those individuals with a personal or family history information, knowledge. In order to do that, the results of the test you're offering them should be easy to interpret. And of course, they should be able to influence their medical management. So it's important to make sure which genes you are deciding to include in these genetic panels so that you have the maximum of knowledge. Despite the rapid uptake of multi-gene panel testing nowadays for hereditary cancer predisposition, there is still limited guidance surrounding the indications for which genes you're going to include in these panels. Here you can see many large case control studies, association studies, that of course have tried to analyze the association between putative cancer susceptibility genes and certain hereditary cancer syndromes, so we can come up with certain genes we're including in our panels. So here are some of the genes included in a multi-gene panel. Genes are divided in high-risk genes with the two protagonists, of course, BRCA1 and 2. Other high-risk genes like PAL2, TP53, STK11. Moderate risk genes, like, for example, CHEK2, ATM, that are already established, well-studied, well-known, but also other genes, intermediate risk genes that are arising lately, like, for example, RAD50, RAD51C, and some low-risk genes that, of course, we probably don't know how they might affect this genetic predisposition, but still they should be included. Probably they will give us information, add knowledge. And we should have in mind that we can have a certain hereditary cancer syndrome, for example, breast syndrome, and we can have many, many genes predisposing to this cancer syndrome. Here you can see the risk of a person, a female, developing breast cancer up to age 70 or up to age 85, in case she bears pathogenic variants in all these different genes. Or one gene alone, for example, BRCA1 gene, how pathogenic variants in this gene can predispose for different cancer syndromes, breast, ovarian, pancreatic, prostate, in the same family. The European, of course, the ESMO and the NCCN guidelines have included all these genes in their guidelines. And don't forget, we're not only talking about breast cancer, but of course there are now well-established guidelines revised constantly concerning other hereditary cancer syndromes. They are included in NCCN guidelines. And this is our panel, getting help from all these NCCN guidelines, the association studies. We have designed the hereditary gene panel. It is a panel that includes 52 genes with cancer predisposing genes to different cancer syndromes. You can see them here in alphabetical order. In the vertical columns, you can see how all these different genes are associated with different hereditary cancer syndromes, and how each one of them in the horizontal lines is associated with a certain syndrome or certain condition. And of course, some of these genes are HRD genes. So it's a panel including 52 genes covering all the cancer susceptibility genes for all the known hereditary cancer syndromes. And one thing is which genes you are going to include in your panels to take the maximum diagnostic yield. On the other hand, you need to decide who should be referred for genetic testing to maximize the knowledge, to maximize the information. Here, of course, we do have NCCN guidelines that propose, of course, that all individuals that have a blood relative with a pathogenic, likely pathogenic variant detected should be tested with such a panel. Also, individuals that do meet the criteria we're going to see below with a personal family history, probably already tested with limited gene panels and proved negative, but still have a personal history, should also be tested. For example, such individuals with variants, pathogenic variants detected in their tumor sequencing test. Or in cases they do have a personal history and we suspect that such a genetic panel testing might aid to their systemic therapy and surgical decision-making. Individual who meets the Li-Fraumeni syndrome, the Cowden syndrome, Lynch syndrome, for example, and this is really important. NCCN guidelines propose that all individuals with personal or family history of breast, ovarian, pancreatic, prostate, or colorectal cancer should be tested. And of course, they include individuals of certain ancestry or personal history of endometrial cancer. Aside from the general testing criteria, we have, of course, certain specific criteria for breast cancer susceptibility genes. All individuals with personal history of breast cancer under the age of 50 years old should be tested with such genetic panels. Of course, at any age with certain treatment indications, with certain pathological or histological findings like triple negative breast cancer individuals, individuals with multiple primary breast cancer, lobular breast cancer with personal or family history of diffuse gastric cancer, of course, individuals that have developed male breast cancer and individuals with certain ancestry, and the same, of course, aside from the personal history, also individuals with certain family history, again, with a close blood relative with one of the following cancer types. And the same, of course, concerning ovarian cancer susceptibility genes, personal or family history. This was not always, of course, the case. These NCCN guidelines are really the recent ones, but that was not always the case, and they have been changed the last 3 or 4 years. They have evolved. In 2019, the NCCN guidelines were really limiting the individuals that should be tested. So that was the publication in Journal of Clinical Oncology that posed the question, are genetic testing guidelines a tool or an obstacle? And they showed exactly that if they followed the limited NCCN guidelines, that were saying you have a breast cancer patient, BRCA1 and BRCA2 are okay, they would lose 45% of the patients. Almost 1 out of 2 likely pathogenic variants would be lost. So after that, the ASCO, the American Society of Breast Surgeons, proposed that genetic testing should be available to all patients with personal history of breast cancer. Many efforts were done. The Mayo Clinic hybrid approach of testing proposed that all women diagnosed with breast cancer by the age of 65 and limiting the NCCN criteria for older patients should be used. And it was, of course, proven that if you limit your testing criteria, you can see here with the blue color the percentage of pathogenic variants that would be lost if we use the limited NCCN criteria. For BRCA1 and BRCA2, more than 1 out of 10 diagnoses would have been lost. And we can see the NCCN criteria evolving because in 2019, they just say consider multigene testing. In 2023, they recommend multigene genetic panel testing for all members with the criteria I've already mentioned. Now, let's go and discuss a little bit about the interpretation and management of the results and the clinical utility. This is the flow of our work in the lab. We receive the blood sample or saliva sample. We proceed with the DNA extraction. We prepare our libraries to be sequenced. We go on with the data analysis with the valuable help of a strong team of bioinformaticians we do have in GeneCore. And finally, we do the interpretation and the reporting. We know that the moment we add more genes and we open up the criteria to multigene panels, to whole exome or whole genome, that it's now the present in genetic analysis, the more are the variants we're going to come across. And the thing is to interpret the clinical significance of them. So we're constantly using, of course, population and disease databases, the help of the literature, computational tools with the help of our bioinformaticians, and with the help of ACMG standards and guidelines, we can characterize all of our variants, and really most important, concerning the variants of unknown significance, to reclassify them. We do have NCCN guidelines. They're always revised. They are there to help us in case we do find a pathogenic variant in a certain gene included in our panel testing, to provide us with the absolute risks in red boxes. In some cases, to connect genes that were not connected until now with new hereditary cancer syndromes, and of course, provide us with risk reduction management. We do have all this information. You know these things, they are available. We always provide our physicians with the NCCN guidelines the moment the pathogenic variant is detected in one of the individuals tested. And here is probably the summary of this information. Excuse me, how pathogenic variants detected in one of these genes can be connected to discussing the options of risk reducing mastectomy, recommendation or consideration for risk reducing salpingo or oophorectomy, hysterectomy, or in the case of CDH1, of course, prophylactic gastrectomy. The VUS, we come across them in lots of cases. It's our job, of course, to characterize them, to classify them. They're variants of unknown significance. It's usually what the patients are asking a lot when they get the results finally. What are these VUS? Keep in mind that they should not be used in clinical decision making because they're not clinically actionable. Of course, we have them, we put them aside. We always take in mind new functional studies, expert panels, and clinical databases to help us reclassify them. Here you can see a major work published a few years ago that in an amount of 45,000 VUS reports, they managed to downgrade almost 98% of them. We see the same in our results in GeneCore reports that the last years we managed to decrease the number of VUS we are reporting because we managed to downgrade them. And here is a similar job we've done in GeneCore. 99% of the VUS that we reevaluate constantly were classified as not pathogenic variants. And for that 1% that upgraded to likely pathogenic, we constantly revise them every month, and we send back to the physicians and the tested individuals amended reports. Data sharing is really important for us. We want to share knowledge, really important for all laboratories out there. GeneCore Medical SA is recognized as one of the 17 genes laboratories, clinical laboratories worldwide that meet the requirements for data sharing. And what's really important, according to NCCN guidelines, is that we also verify our likely pathogenic results before we release them. That means we don't stay to the initial result taken by NGS. In case of a pathogenic variant, we verify our finding with an independent methodology, for example, Sanger sequencing or MLPA, if we're talking about single point mutations, or CNVs respectively, from an independent DNA sample. It's really important, and I'm staying to this point because it's not necessarily the routine for all diagnostic laboratories out there. All the steps I've mentioned are, of course, under external laboratory control steps and internal laboratory control steps, accreditations and certifications. We try to publish our data. Here are some of the publications of the hereditary cancer syndrome lab. I'm staying to those that showed the value of multi-gene panel testing. Here is a work published in 2019. You can see the percentage of our positive pathogenic results. You see how the percentage of the pathogenic results in really many different genes, okay? And we see the value of using such genetic panels. We can shed light to new genes that we didn't know before. And of course, here are likely pathogenic variants stratified by gene risk category. Another publication that shows exactly how the pathogenic variants can be divided into high risk, moderate risk, low risk, or of course genes of insufficient risk, but still they need to be there in genetic panels. A considerable number of tested individuals that carried two likely pathogenic variant, the double heterozygotes that this work managed to show. And of course, what I was telling you at the beginning, that in case we use the limited NCCN criteria, we showed that we would lose approximately 10% of individuals positive for a pathogenic variant. They would be missed. And here, of course, how our findings, the positive findings, are connected with treatment implications that are useful. Now, when communicating the results of the genetic test, there are multiple levels of information that should be included. It involves information of how about the way that heredity contributes to breast cancer, and not only that, how results could affect the management of breast cancer in the patient, actions associated with the reduction of the risk of recurrence to the tested individual, and of course, the relatives at risk. And finally, evidence-based information on how testing results can be used for treatment. Okay, I will not spend time talking here about treatment, but of course, our heredity panel to revise includes 83% of genes that are included in NCCN guidelines. 67% of them, they do have management options. They are of clinical utility. And of course, 21 genes are involved in homologous recombination. So it's a really valuable tool. We can see the last recent years, the different levels of information add quantitative and qualitative changes to the clinical utility of genetic testing. We started with just talking about risk management, here cascade family testing. We were proceeding with adding information from multiple findings or even secondary findings. Today, we have added also therapeutic implications. This interaction model, of course, includes the oncologist, the surgeon, and the family. And we are here to wait what the future holds for us. Probably in 1 or 2 or 5 years from now, we're going to be talking about some new things, new genes, new panels. Thank you very much for your time.
Okay, so I'm just going to go over today is the launching day of a new test. We had Prime. Many of you have already been informed about this, but now we have a new version of it. We're very proud. This night is it's a changing. I hope I can transfer this excitement to you. It's a changing moment for us in the lab, hopefully for you in the clinic as well. So the first evolution, the panel used to be 500 plus genes. Now we're talking about more than 1,000 genes, which in clinic, it doesn't say much. The number of genes are not always related with more information, but it gives us a better understanding of the alterations in the biology of the tumor, and I'll show you how and why. So what we're trying to do is we're looking at different kinds of mutations in several genes, somatic genes, for treatment decisions. Okay, we're talking about usually advanced cancers, or I'll show you, rare cancers maybe, where we're looking at CNVs, insertion deletions, and all types of alterations. But at the same time, we're looking at immune response. We're looking at tumor molecular burden, MSI, HLA, and also PD-L1. So we're trying to see what are all the alterations, and when we keep throwing out, this doesn't like to work. When we keep throwing out the words like, copy number alterations, we try to be cool as lab people because usually we're not. So it's practically this extension of in the gene, or substitutions where a part of the gene goes to a different place that it should not be. Insertions or deletions, something gets added or deleted exactly as it says. And translocations, my personal favorite, where things get really, really messed up and whole parts of the gene go and stick to other places that they should definitely not belong, because these are usually, all these can be driver mutations for cancer. So what we're doing is 1,000 plus gene testing, and also we look at 38 gene fusions, as I said, also TMB. And the exciting part is that we do it both on paraffin-embedded tissue, but now this new platform allows us to do it also on liquid biopsy. So for the first time, we're able to have TMB, MSI on liquid biopsy besides PD-L1. And the purpose, of course, is to give you tools to find targets and personalize the treatment of your patients. So the highlights of this is that we can identify more biomarkers. This could be clinically relevant or not. We can provide you more information about immune response, immunotherapy response. We provide you with prognostic biomarkers, also biomarkers that responds to chemotherapy, even though with limited level of evidence. And at the same time, you get also clinical and research information, meaning open clinical trials that are ongoing, so you can get more insight about the tumors that you're dealing with. And as I said, also performed on a liquid biopsy test, which is only the beginning. It's like those advertisements on TV, the telemarketing, no, but wait. So who should be tested? It's not for all your patients. It's not a routine test for everybody. Aggressive tumors with no standard treatment, I don't know, pancreatic cancer, maybe. When the initial treatment plan has been completed, but more treatment options should be taken, especially patients with good performance status. Many treatment options, non-small cell lung cancer, for example, where you have too many options over there. With no gold standard, maybe triple negative breast cancer. Cases of unknown primary, where all the guidelines now are saying that it doesn't matter to identify the primary, but to treat it. So multi-gene testing is strongly recommended for them. And of course, for response to immunotherapy, as I mentioned. And mentioning immunotherapy, there's 30 plus biomarkers with correlation to treatment or prognosis. So you have biomarkers with positive correlation reported on the test, negative correlation, which means that you're going to find resistance, no response, and prognostic factors related to patients undergoing immunotherapies. So these biomarkers are affecting they have this curative effect, meaning they affect the way that the patients respond. And we're talking about, the known TMB and MSI, but also PDL amplification and all these genes that are also related to the prediction of indication and affecting the curative effect, which should have either positive, negative, or hyperprogression patients. Now, this test is CIVD, which is another fabulous European regulation, which from the year next year, 2024, May, I believe, all the tests that you use should be CIVD. In vitro diagnostics is the IVD testing, the IVD meaning, which means that all these have to be approved by a committee in the European Union. So all our tests going on are CIVD tests from now on, everything that comes out. So this is CIVD test. I'm going to put this all in a timeline. There's several publications about this, and we still keep finding exciting data as we go on in the clinical use. I'm not going to bore you. I think you saw too many studies today. So all these are findings based on this specific panel and the way that it was developed. So both on the development, so the clinical usage of the test. Well, because the test was initially developed as a panel, it was developed in China. So this is why the initial studies were done there. But now, since the beginning of the second quarter of the year, it's in Europe available, and it's been after the CE mark validation. So you see here, I'm not going to go over the genes, don't worry. So if we look at many genes, it's a big size of the genome. So we produce a lot of data. And in order to analyze the data, exactly as Dimitra mentioned before, we need bioinformatics. So you've seen the slide. We need to go through the process in order to be able to correlate what we find with what is on the first page of that report that I'll show you in order for you to make those treatment decisions. Did it beep? It was not a beep. No,
Not yet.
not yet, surprisingly. So I'm not that far away. So this is the first page of the report, where I believe that here you find the report, by the way, if you print it, is on average, depending on the patient, approximately 50 pages. So do not print it. It's interactive, so you don't want to print it, so it's clickable in many pages and many points. I'm not going to go over the 50 pages. I'm just going to show you that in this case, there's 2 clinically significant biomarkers identified when we analyzed all these genes, and we found 5 biomarkers with on-label drugs. So this is just an example. These are the findings, and of course, all the information about treatment options are provided. And the second page of the electronic version, let's say the trees, are clickable references, so you can just jump to the page that you want to look at, which is gene information, drug information. It links you to drug databases. If you want to see further information, it links you to trials.gov for the clinical trials available for this specific finding based on the indication of the treatment cancer type of the patient. And overall, it provides you a tool that can really, depending on how deep you want to go into this, into looking into it, you can really uncover the whole biology of the tumor that you're dealing with. So in a time frame, in the beginning of the year, we focused a lot on the development of a cost-effective, because that's the second breakthrough. It's cost-effective, not cheap, cost-effective.
How much per plate?
I'll tell you, I cannot do the division, but the test is 1,450 euros for all the information given.
Not bad.
Well, the previous version was almost 2,500, so we're very proud of that. Again, validation and liquid biopsy, the CE-IVD. So we were trying to identify that we can actually perform the test on paraffin tissue and on liquid biopsy. And then going on, bioinformatics and the report that took longer than you think. And of course, today we're launching the test, and this would be Q3. And then the plan is until the end of the year, in the same test based again on liquid and or on paraffin embedded tissue, to provide also the HRD score. So to use this information in order to calculate the HRD score and provide it to you in order to be able to, for those patients that have indication for olaparib. And in the beginning of next year, we are focusing on including follow-up MRD testing. So looking, identifying, you perform the test today, 6 months from now, you want to see the response or the molecular or minimal residual disease. And on a blood test, which doesn't cost as much as the whole panel, just specific markers are being identified, different for each patient, and you'll be able to follow up with a patient. And this is the future, including the MRD. So we're going to be able to identify specific biomarkers based on the test, analyze them, and give you practically this. So for instance, this is a patient that took neoadjuvant, did neoadjuvant therapy, and then they had response, and then doing monitoring, you see an increase on the MRD, on the minimal residual disease markers. So you start understanding that relapse is on its way. So probably closer imaging, probably closer follow-up, and then at the relapse, you're able to identify biomarkers to change the treatment. Today, guidelines do not allow you to change the treatment beforehand. You have to see the relapse before you treat it. And this is reflected, this multi-gene testing, not the MRD yet, but the multi-gene testing is reflected in many cancer types by the NCCN guidelines, especially the recent ones. So you'll see that in pancreatic cancer, they're definitely recommending multi-gene panel testing, especially when we're looking also, in addition, actually, in biliary tract cancers. I'm not going to stay much. Non-small cell lung cancer, old news. For years, it's been recommended. In colon cancer, also nowadays, it's recommended to do multi-gene testing. And also in breast cancer. And also in breast cancer, we see what we used to see a few years ago in lung cancer, where they had the emerging biomarkers on top. So there's a lot of involvement towards this direction, both on a regulatory level and also on the guideline clinical usage level. And I can keep going on and on for ovarian cancer and prostate cancer also. And I'll show you a very interesting case that was actually last week, I believe last week, in August, actually, last month in the laboratory, where liquid biopsy test on a prostate cancer patient, and it came back as a BRCA2 positive patient. And keep in mind, with this test, especially in the liquid biopsy, it's like doing somatic and germline at the same time. So you get the information both on the genes related to treatment, but also you get information for hereditary cancer. So this patient with prostate cancer did not know that they had a BRCA2 mutation, which affects definitely the treatment, but also family planning, whatever includes hereditary cancer that we just mentioned earlier. So based on the report, you got information about the type of mutation, and of course, these are clickable, as I said, and the doctor can click on it in order to go to the drug databases and get more information if needed. In this case, maybe not. And I think I did it in less than 10 minutes. So in a nutshell, this is my last slide, I promise. It's cost effective. It can be done on paraffin tissue and on liquid biopsy. It's validated and also CE marked in the IVD. And it's most informative with addition, as I said, with immunotherapy response and everything. And in the future, near future, we're expecting even more add-ons to this test. And it becomes a tool where you test somebody now, but then you can use this expensive and valuable information in order to follow up your patient as the treatment goes on. That's it. Thank you very much.
Baltics.
Yes. Like being Baltics.
It means that this is not cosmos somewhere, but it is our real life, what we can do. And as I understand, yesterday or days ago from our meeting, laboratory meeting, we are here that everything is very easy from practically point of view. For this parameter testing, we need to send vial with blood and.
Well, I'll tell you, practically speaking, sometimes you have tissue is the issue, as they say. So many times you have cancers, for example, lung cancer, where you have just an FNA sample and it's already used by your pathology lab. And then we're stuck. We don't know what to do with that patient. And the liquid biopsy options are either just a couple of genes, and if you catch those. So in this case, you get the option. I'm not sure how available are drugs on label or off label in your countries and how difficult it is to go into this, but nonetheless, you always have an answer to give your patients of what else can be done. And in the cases where speaking, I'm sure that Ilse, this is what she wants to mention. For instance, you have a patient and we run FFP, and for some reason it fails. So then with no extra charge, we just ask for a blood sample, we send you the special vial, you give us a blood sample, and we run it on liquid biopsy. So every patient gets an answer. So we don't have patients that are dropped out because there's no tissue or there's no, and also, I mean, you know better than me as treating physicians that if I do a biopsy today, and meanwhile, my patient takes any targeted treatment, then this biopsy is no use. Because most likely what is left, the biology of that tumor is slightly or completely different after a relapse in the future or metastasis. So, and many patients are not in the performance status that they can be rebiopsied or even access to that tumor may be not available. So we're trying to give answers to all the patients, at least the vast majority of them.
Analysis is performed in 20 days.
In 15 working days, it's
15.
3 weeks. 3 weeks later, you get your result.
But Nick, tell how, for surgeons, how it comes that you can do both somatic and germline in a liquid, because the somatic you do from tumor DNA, which circulates, right? But germline you need to do from some lipocytes, healthy or whatever.
We analyze both. Practically, what we do is we
And
look at
1,000 genes for both.
we look at all the genes, and when you have a mutation on the blood, on the liquid biopsy sample, which is in more than 50% of the frequency of the alleles, then it's pathogenic. It's hereditary, because more than half of your, in a very simplistic way, of your DNA has it. So most likely it's something that is, not most likely, definitely it's something that is hereditary. Now, you can get the same information from the paraffin block, but you have to confirm by blood. In this case, you have the blood, so you just confirm it automatically. I don't know if I'm missing anything.
Yes.
So, yes, it's also a big deal. Struggle for that.
Experience with promotion.
Yeah, that's like $5,000, yeah.
From logistic point, it's like tissue is.
Oh, yeah. Just for the liquid biopsy, we just have to send you, it's not EDTA. It's not like you would send a hereditary gene where you just use the regular EDTA vials. We provide you with special, they call it Streck vials, where they, practically what they do, they have a medium inside where they protect the structure of the DNA and the RNA, which we need in order to be able to do the test. So it doesn't degrade.
But you need to have tumor in imaging visible to send the liquid biopsy. Or in other words, there could be cases that you say that there is no tumor DNA.
Okay.
Liquid biopsy.
Great question, actually. So, and if you have a liquid biopsy and everything comes back negative in the report, you're not going to say that this patient does not have any findings, because most likely it's under the limit of detection. We have a 0.5% limit of detection for cell-free DNA. So what we do also with no extra charge is that we recommend that 3 or 6 months later, you take another liquid biopsy from that patient and we retest free of charge in order to make sure that it's a real negative. I mean, it could be that none of these 1,000 genes are mutated, or that really it was under the limit of detection. And as time goes by and the cancer through apoptosis, necrosis, it releases that cell-free DNA in the bloodstream, then it goes, it increases the cell-free DNA in the bloodstream.